Top Bed Talk.
Hello, I'm Scarlett McNally, and I'd like to give you a surgeon's view on perioperative care, how we can make it better and how we can use it as a model for all of health. I have no conflicts of interest. I'm Deputy Director for the Centre for Perioperative Care, been a surgeon for a number of years, and I've been on the Council of the Royal College of Surgeons of England since 2011. So I think there are several big wins, only around reducing complications and understanding and discussing risk, which leads into better shared decision making, which in turn leads to patients who are more satisfied, but also many who decide not to go ahead with the operation but remain satisfied. We've got some work to do around pathway redesign and around team working. So as an example, the World Health Organization has produced a report fairly recently showing that people who stop smoking before their operation reduce the risk of complications by half. And that happens quite quickly, so stopping smoking just for 4 weeks can reduce complications by 19%, which goes up by a further 19% each week. So this is really, really worth doing, even for example, cancer surgery that's got very short lead-up time. Exercise is also important. I was lead author for this report from the Academy of Medical Royal Colleges in 2015, and this is about exercise, the miracle cure, the role of exercise in preventing conditions from ever happening, and also in treatment of those conditions. So the numbers there are if somebody is exercising at the rate of 150 minutes a week, so half an hour, 5 times a week, for example, and the impact it has on these very common conditions. And this is huge. And these are all the conditions that we've become increasingly aware of, or the public is now aware of, with the COVID-19 pandemic, as unfortunately leading to worse outcomes for people who contract the virus. It's also the comorbidities that are present within the population we're operating on. So the waiting list in February 2020, just for England, for the common specialties of trauma and orthopaedics, general surgery and urology, there's over 1 million people either waiting for assessment or treatment. And most of those will have 1 or 2 or 3 or 4 comorbidities. So this is entirely the surgical population that we are dealing with every day. There are also emergency operations, and many of those are in patients with multiple comorbidities. Now, people think about nutrition and exercise as being lifestyle choice, but in fact, a choice is very limited for some people. It's based very much on someone's social situation and their environment and what's considered normal by their friends and their family. So in order to achieve change, you need to get the person's family and culture on board, but often legislation or regulations have been most important in achieving change in other areas of public health, such as road traffic collisions and smoking. The biggest wins for reducing complications for patients who are on waiting lists are around smoking, exercise and nutrition. And these don't just work on the heart and lung fitness or tissue oxygenation, they also work on inflammation and on metabolic changes. There are other things such as alcohol and drugs, mental health, medication review and psychological preparedness that are also very important. And for some patients, just feeling that they are in control and doing something can be very powerful for helping them to get the best result. Now, surgeons in general hate complications, obviously. They also hate cancellations. For example, someone doesn't have a HbA1c result back in time for their operation. They also dislike being expected to operate because someone's told them to do so when they haven't had the chance to assess the patient themselves. And also data that shows their unit is not performing as well as it could. But surgeons still don't really get involved in lifestyle discussions or prevention. And why is that? Is it because we don't know the scale of the benefit? And there's a possibility that's true. We don't want to jeopardise the doctor-patient relationship, or we assume that it's already been done and has failed. But really the big reason is that we think other people will do it better. And we're probably right, other people do it far better. But unless surgeons talk about it, acknowledge it, say a few pointers, then it's not valued, it's not considered as part of the whole care package. For people that want to learn motivational interviewing, my best tip is to do the course on movingmedicine.ac.uk, the fast one. You can learn in 1 minute how to explain about exercise in a 1-minute consultation. There's also the Making Every Contact Count resources, which are free to anyone with an nhs.net email address. And that's e-learning, which is very good. And I think all administrators, managers, receptionists, staff, including clinical staff, should do this course. And for clinical staff, it's really asking permission to talk about something that might change someone's outcome, but assessing with them what they can do together and giving advice. And sometimes people are swayed by numbers, so doing exercise every day reduces complications by up to 50%. At the Centre for Perioperative Care, we've been doing work with Macmillan around patients preparing for cancer surgery. Often there's short time lead-in times before their operation, and this has a very large effect on people's well-being and preparedness and their fitness and reducing complications. Just wanted to mention that I was quite ill in 2019, and I think even for me, with my background, it needed the GP and the consultant to tell me that I had permission to do exercise. This was at a time I couldn't even climb a flight of stairs, and I thought that doing more exercise would be bad or would spoil my health. So here I am on the exercise cycle at the Macmillan Centre, and I've built up from there. But it's not all about providing exercise cycles. We need people and their families to ask for them and to know it's important. So people who are waiting indoors, for example, 14 days self-isolating before an operation, so they have a negative coronavirus screen, could be advised to get an exercise cycle, treadmill or rowing machine so that they can keep up their daily exercise, those 20 minutes a day that are so important. People that are able to get out, I'd recommend an electric cycle, because then you're never caught out if you need to come home because you've taken on too much and you're not interacting with other people it's quite such a close distance as you might be if you're worried about infection. We've got 1.5 million NHS staff that ought to be role models for good behaviour around health, and also being prepared to talk to people in detail about it. We need to change what's normal and demand facilities to allow people to have good exercise and good nutrition. For nutrition, some of it is simple messages around smaller portions and 5-a-day fruit and veg. There is an issue around some patients who would do better with lower carbohydrate rather than low calorie. For some people, it works better at reversing diabetes than the traditional low calorie approach. Surgeons should really be using risk tools to estimate the risks in their particular patient. So they can use these tools to discuss with the patient what the likelihood of problems will be and work on fixed risks and modifiable risks. And for patients, we need to discuss their expectations. More reports are coming out with patient-reported outcome measures, and about 10 to 15% of operations will have a complication, and about 14% of patients express regret after their surgery. So it's useful to work with patients on what they are expecting to help with shared decision making. Similarly, some surgery is not as evidence-based as we think. This is a statement from the British Elbow and Surgery Society and British Orthopaedic Association about arthroscopic subacromial decompression in the shoulder not having such a good outcome compared with no operation at all. That was in 2017. So we have changed our practice. Similarly with hip replacements, there's a 3-fold variation across the country, and there are other health conditions and operations that have similar variation. Now, is this due to unmet need, or is it different criteria for whether people operate, or different non-operative approaches available? Now, during the pandemic, people are not wanting, quite rightly, to take on the risk of surgery in some cases. And some of those things we were talking about as improving people's fitness for surgery are also the things that improve the condition to reduce the need for surgery. So this is just an example on how to manage bone and joint and muscle pain that's out from 7 very respected bodies that patients can use as an alternative to surgery. So that information is out there and available and can be discussed. The risks, as we've said, of the COVID-19 virus is that if people contract it during or after their surgery, they have a much worse result, with perhaps 51% pulmonary complications or 24% mortality. But bear in mind, evidence has only just started being collected, and in this particular cohort, not every patient was tested, so it's sort of overestimating it. But the numbers are quite worrying, and quite rightly putting people off either having surgery or for surgeons performing surgery, unless everyone fully understands what's going ahead. We also have information available on the CPOC website for patients about how to get fitter better sooner for their operation, and other more specific information on the Surgery and Specialty Surgery Association websites about individual operations. And this is quite important, so we set the expectations. It's also quite important because all the staff working in the service can use patient information as their means of learning, what they can refer to explain to the patient, their relative, their carers, what things involve, because it's written on the sheet. They're allowed to say it. Even if the patient's the expectation, the surgeon, the doctors, the anaesthetist will go through exceptions with them, but we have a standard pathway. So this is quite a helpful shared decision-making tool, particularly for surgeons who haven't come across it before. So what would be ideal from the Choosing Wisely initiative work is if the patient comes prepared, ready with what are the benefits of the surgery, what are the risks, what are the alternatives, and what happens if I do nothing. And that helps have a conversation at the right level where everybody has a shared understanding. Just bringing in another example here, I accompanied a very elderly relative to the breast cancer follow-up clinic, and she was advised to have a mastectomy. Now this patient, my relative, has such dementia that she would have woken up every day for the rest of her life wondering what had happened and being upset by it. And the alternative we had to coax out of the clinical team, and the letrozole tablets are working very well some years later, and that was an alternative that hadn't really been offered well enough, bearing in mind her mental state. She's doing very well, and she's going for a walk every day now as well. So shared decision making has almost been taken over by the primary care and community care as if that's the best place for it to happen, which indeed it is. But we do need surgeons to be part of the pathway, partly so the patient doesn't feel that they're being denied something, so it's accepted as better care or as good care. And also that they're not being rationed by it being something that the NHS has set up to save money. When shared decision making is introduced to clinicians, some think that they do it already, and some indeed do, but actually we could all do it a little bit better. And this is a reference to the MAGIC, the Making Good Decisions in Collaboration initiative, which is about training people in shared decision making. The other thing with surgery is that traditionally the multidisciplinary team, surgeons sometimes think of as the MDT meeting that happens once a week between the radiologist, pathologist and surgeon. And what we need to do is to make sure that the patient is somehow included in the discussion or the options afterwards, rather than it being a diktat that's come from the MDT that has to happen. The Montgomery ruling has changed how surgeons do consent. And it's now very clear that we need to discuss the individual patient expectations of surgery and what they would attach significance to in terms of likely or possible complications. And that has really changed conversations and consultation styles. Just to say as well that perioperative care is surgical care. These are just some extracts from the Joint Committee on Surgical Training syllabus for core surgery of what's expected for those trainees that have completed that. And similarly, the Getting It Right First Time initiative includes many things we've been talking about in terms of reversible risk factors and working better in teams, and perhaps going to visit the best performing teams to see where our own unit can do better. Now, in terms of the whole perioperative pathway, if you look at it from the end of the completed episode, shall we say, which many people organising the health service do, it almost seems that it's an inevitable journey. And yet there are many points where someone might have a better outcome by not going ahead with it. And we need to acknowledge that many patients might prefer a different route if they have all the information about the possibilities. We need to change the pathways, and we've talked about improving processes with risk scoring, getting the results at the right time, which reduces cancellations on the day or shortly before when there's no time to reschedule, and when there's a chance to improve things. We need staff who are doing the pre-assessment not only to document the patient's risks, but to talk about how to reduce them. And it's about communicating risk. Now, one can even change pathways for emergency patients where it feels as if there's not enough time to prepare them, because one can set up something that is automatically done, even for patients that arrive out of hours and during an emergency. And I recommend the POTS initiative, Perioperative Care of Older People Undergoing Surgery. It's very helpful to have some standardised criteria and pathways, because otherwise there's a risk with surgery that one surgeon's identified a particular nuance or particular individualised bit of care that applies only to that patient. And you need all the staff working on that team to realise that there is a standard pathway and a standard expectation, and the individual, I'm not going to say idiosyncrasies, but there's for a patient's particular condition, they need that discussed with their surgical team or the anaesthetic team. But for everything else, there should be some standardisation. So this is just from the British Orthopaedic Association about different conditions. On this graphic, the little grey dots are patients, and the area of the shape is the amount of money spent. So 7% of patients are responsible for half of all hospital costs in acute trusts. And these are the patients who have complications, unexpected care and lengthy stays. So this is really worth working on. Good care is efficient and cheaper. But from the patient's point of view, they need to know they're getting the best care, not that they're getting the cheapest care. We have an issue with teamwork. The invited review mechanism is a service from the Royal College of Surgeons of England where we go into trusts, we're invited into trusts where there have been problems with the surgical service. And in 76 out of the last 100 reviews, problems with teamwork were found. So, for example, the team not meeting regularly, which meant they couldn't discuss how to improve the service or deal with their own data or quality assuring it. And an absence of agreed working practices such as handover, or the presence of agreed working practices that were then not always followed. So some of these things are ripe for improvement, using some of these things of where to focus. The Academy of Medical Royal Colleges has just produced a document on team working and education about how to form your team and storm it and make it normal, with feedback using data, valuing every team member, and also working out what everyone's strength is so that people can refer appropriately and use appropriately, but understand where to fill in the gaps so that everybody has a basic knowledge of what each other person does. I find this graphic quite helpful, that the iceberg of practice, that people can't always see why you do stuff, they can only see what you do or your behaviours. So sometimes it's useful to verbalise why you're doing things, and then the rest of the team understand what things are important. And there's some sort of cognitive dissonance, that we kind of assume that the general things are different from the specific things, or that complex things almost take priority, whereas sometimes there's a simple message that needs to be said, and the complexity just added for the individual patient as it's required. So, for example, surgeons often think they're going to get absolute perfection, but you can only get it perfection for a limited amount of time in the operating theatre, in my experience. And the reality is you need to work with the team and make the process as good as possible for normal, and accept that sometimes a member of staff will be having a less than perfect day, and you need the systems in place to make sure you've got everything as good as it can be. Similarly, there's some cognitive dissonance in the public and in the decision makers and the voters. We all would agree that we want the best care for everybody and the most cost effective for the UK's gross domestic product. But actually, when it comes down to yourself, you want the best possible care for you or your family. And people see those as different. And we need to explain really that within the NHS, those can be the same. The cheapest option might be the best option, but it needs to come from the people who are capable of delivering that best option, in my opinion. So to do that, we really need to set the expectations. So you set the rules, explain the normal pathway, empower every staff member to follow the pathway, adhere to the rules, and identify the exceptions and the red flags. Just as an example, this is from the Academy of Medical Royal College's Exercise Miracle Cure document. For most patients, it's just a question of getting started on exercise and doing a little bit more. So over 95% of people just build up, start, and anyone can tell people to do this. But you need to identify the 5% of patients where it's very complex. They've got severe COPD, or they've just had a myocardial infarction. And for those, you'd want to refer to an exercise professional rather than going down the normal route. We've also got some work from the Royal College of Surgeons of England on team working. So this booklet on avoiding unconscious bias is about being clear about the role, about when there's a problem, feeding back about the task that's happened rather than the person, about being polite even if it's someone's job to do that. And again, if there's a problem, asking the person if they're okay rather than making an assumption. And sometimes you need some skills for what's going wrong in the moment rather than trying to tackle everything all at once. So you just have a safety moment, and then it might be that later someone can talk to the person about how things could be done better. And I recommend the Vanderbilt cup of coffee approach, which is a peer-to-peer discussion with somebody that they respect, just asking what they think could be done differently. So again, there's quite a lot of work going on, particularly with the Royal Australasian College of Surgeons about the Respect Initiative, but this is really fundamental to team working. The critical thing is people don't really think about the impact of their behaviours on others, and sometimes you need to formally talk about it, and I recommend the e-learning we've got for free on the Royal College of Surgeons of England website. Just while we're there about setting expectations, we need to support students, trainees and staff that are new to the area. So we've got some booklets on learning in the operating theatres for all sorts of staff, and some about setting what the surgical curriculum should be for medical students, for everyone who's going to be a future doctor, because it reduces the ivory tower nature of surgery. People need to understand the general concepts rather than perhaps learning about something that's a little esoteric. I'm just talking about the opportunity for better health after the pandemic and for better perioperative care. There are several areas where things could be better. For example, we've had unprecedentedly low bed occupancy, and we could continue with this in order to ring-fence beds for surgery, which prevents complications. You need a few empty beds every so often to cope with the peaks and flows in surgical practice and keep an area ring-fenced so it's safe and with a lower infection risk. We also want to keep some critical care beds so that patients who need a critical care bed post-operatively can get it to improve their outcome. There's been a lot more discussion of risks and the public's understanding of comorbidities, and we can discuss shared decision making and what's best with the patient. There's been much more working across teams. And the other thing, the change in virtual communication, virtual assessment of patient and education on webinars and so forth has been massive just in a few weeks. The other thing that's been massive, just last on that slide, is being able to have virtual meetings. So this enables the whole team to talk about a potential change, rather than the discussion only happening between the people who are able to get to a physical meeting or often very busy with other things. Now with virtual meetings, people who work part-time, people who work on different sites can be included, look at the data together, and it's much better for sharing and making a change within the NHS together. Just while I have your attention, something about setting expectations. There is a rule book. It says if there's not enough room to overtake, don't overtake. Some people really just don't notice that they're doing that, they're too close. And you need to sometimes explain in order to change the culture. My link in this is if we can get things safer for people to cycle, people will be healthier and there'll be less pollution. Just to recap, the same things that reduce complications help better health: smoking, nutrition, daily exercise, alcohol and drugs, mental health, sleeping well enough, looking after your relationships, medication review, perhaps deprescribing in some cases, and psychological preparedness. And on those, diabetes, obesity and anemia also can be viewed. There's a lot of information on the Royal College of Surgeons of England website. You just look at the resources to get the archive of webinars, you look at the search box for consent, and we've got our unconscious bias training on the front page. And again, there's lots more learning on the Centre for Perioperative Care website, cpoc.org.uk, and do follow us on social media. So thank you very much.
Top Med Talk.
Thanks for listening to Top Med Talk. We are excited to announce the World Congress of Perioperative Medicine happening in London this year. Check it out at ebpom.org. It will take you through to our carbon-free conference center where it has the EBPOM platform. You can find more information. Be sure to subscribe to Top Med Talk and EBPOM at ebpom.org.